Good evening, and thank you for attending AACP's webinar with Dr. Daniel Klauer, presenting Strategic Growth Strategies, Insights, and Live Q&A. I'm Shaylin, the Association Manager for the AACP, and I will be the host of the webinar tonight. This webinar is approximately 60 minutes and will have an interactive Q&A throughout. Please enter any questions you have in the Q&A box located at the bottom of your Zoom screen, and we will address them throughout the presentation. There are no relevant conflicts of interest to disclose on behalf of Dr. Klauer or the AACP. Registrants can expect to receive a recording of this presentation via email within 10 to 14 business days, and AACP members attending live will receive their CE Certificate of Attendance within 30 business days. I would like to mention some upcoming events for the AACP. Registration is now open for 2 AACP mini courses: Oral Appliance Therapy, a comprehensive approach to TMD and sleep medicine, July 18th through 19th in Raleigh, North Carolina. This course provides a strong foundation in oral appliance therapy and advances into topics such as neuromodulation, phased treatment planning, and appliance use in managing sleep apnea, bruxism, and TMD. And our Advanced Injections course, September 26th through 27th in South Bend, Indiana. Designed as a hybrid program, this course combines pre-course virtual review with hands-on training in injection techniques, blood draws, and osteopathic manipulative treatment. These courses are ideal for practitioners looking to expand their clinical skill set. Space is limited, so reserve your spot today and take your practice to the next level. We also hope you'll join us for AACP's Airway Anatomy Forum, taking place October 25th through 25th in Santa Clara, California. This unique event brings together leading experts from both dentistry and medicine to explore critical connections between midface anatomy, functional breathing, and brain health. It's an incredible opportunity to deepen your understanding, connect with colleagues, and stay at the forefront of airway-focused care. And our presenter tonight, Dr. Daniel Klauer. After graduating from Notre Dame, Dr. Klauer pursued his Doctor of Dental Surgery degree at The Ohio State University, where he completed 4 years of dental training. In 2013, Dr. Klauer chose to limit his practice to treating patients with craniofacial pain, TMD, and sleep disorders due to the overwhelming need within the community. As he learned to identify the origin of patients' pain and sleep problems, it became increasingly clear that he could drastically impact their lives now and in the future. Dr. Klauer has completed nearly 2 years of postgraduate training and over 1,500 hours of continuing education in craniofacial pain, TMD, and sleep medicine. He is board certified with the American Board of Dental Sleep Medicine, American Board of Craniofacial Pain, and the American Board of Craniofacial Dental Sleep Medicine. Today, Dr. Klauer enjoys educating patients and giving them the tools to live healthier lives independent of medications and Band-Aid fixes. In his personal time, Dr. Klauer spends as much time as possible with his wife and 5 young children. He enjoys running and skiing and finds pleasure in almost any outdoor activity. Dr. Klauer, we're very excited to have you here tonight. Thank you so much. I'll turn it over to you.
Great. Thank you so much. So thank you, everyone, for taking the time to listen in and hope to provide relevant information. So these mini courses, it's great content, good hands-on experience. And so I would definitely highly encourage you guys. There'll be some fantastic doctors, Dr. Persley, and others for the oral appliance therapy course. No other course where you get like hands-on opportunity to mess around with appliances, take bites, and different things like that. So July 18th to 19th. And to be honest, the ability of these courses to go on will depend upon you guys signing up. So if we fill the courses, the Academy makes some money. The doctors are basically doing this for free, donating their time, maybe getting expenses covered. But the more docs we have signed up for it, the more likely we can do more of these courses. And then at my office in September, we're doing an injection course Dr. Mark Cantieri is going to be teaching. He's one of the authors of the medical textbook on prolotherapy. He does a lot of PRP, PRF. And so he'll be talking about osteopathic manipulation, injection technique, injection etiquette, all that stuff. We also have Dr. Mark Abrams coming, ear, nose, and throat specialist. He's going to be talking about intranasal nerve blocks, scoping the nose, and doing profound nerve help with unlocking patients, boarding migraines, and we're going to have a nasal endoscopy there as well to better understand nasal anatomy and kind of go through that. And he's going to hold everybody's hands through it. So Dr. Greg Larson went through a lot of work setting up Dr. Abrams to come up to South Bend to do it. And then Dr. Christina Wolf is going to be lecturing on anatomy. So we have a lot of good speakers lined up for that. Right now, I have like probably 50 people told me they want to do it. We have just a few signed up. So if we don't have signups for the first week of August, we're going to have to cancel the course. So I know there's a lot of energy around it. Just need that energy to show up by signing up. So register today and get that going. The Airway Anatomy Forum, Dr. Phelps is hosting in Santa Clara. That's October 24th, 25th. That speaker lineup is unbelievable. Psychiatrists, ENTs, sleep physicians, oral surgeons. It should be a fantastic turnout. We got some good momentum there. Over 60 people already signed up. So get that on your calendars, bring your team. Should be a great event. And then any docs, friends looking to up their game with craniofacial pain and dentistry medicine, encourage them to become members. So today we're going to talk about some growth strategies, some techniques and things we've implemented. And a lot of this stuff, to be honest, is things I've learned from other people. Some of it's unique, some of it's kind of modifications, but I think over the years, I've been exposed to some great content and absorbed that and then figure out how it fits into my practice. So by no means am I claiming kind of ownership to any of these things, techniques, or tips, tricks we do, just stuff that we utilize from my humble experience. And I'm happy to field questions along the way. All right. So I have 5 kids. Oldest son here, Carson, he's 12, down to 4, Annie, the little queen princess of the crew, and then my wife, Haley, kind of a saint, and works part-time teaching dental hygiene. And then raising our 5 kids and volunteering for everything, and saying yes to a lot of stuff. So here's our office in South Bend, Indiana. Just to give you some context, here's a quick video tour. So we kind of have an oversized waiting room and a seminar room next to it for community events and some CE, some team training. Today we had a team meeting in there. And we have a team of about 18 people now. It's our kind of break room. We bring in lunch every day for the team, so they don't have to worry about lunch. That's been a nice value add of being on our team. That's financial room. These are the treatment rooms, kind of the main clinical hallway, and kind of a quick rundown. So at our office, came up with a mission statement years ago, and it's to give hope to patients of all ages by adopting their personal victory as our own. We restore the quality of life they deserve by providing the tools and therapy to decrease pain, increase energy, and improve sleep. So getting your team rallied behind your mission is important, so they know what you stand for, what the values are, what the rules of practice are along the way, and keep everybody aligned. So at the practice, we have myself, Heather, a nurse practitioner, Dr. Sahar, she does all the pediatric airway development, tongue tie, lip ties. Dr. Mark Cantieri, osteopathic physician. He's at our office full time for him, but just 2 days a week. And then Crystal, our myofunctional therapist, and then Dr. Anil Rama, sleep physician, remote. He does all of our sleep studies and follow-ups with patients when needed. Heather, unfortunately, she got married. Exciting. She's now at our Fort Wayne location, about 2 hours away. And Hannah White, a new nurse practitioner, has been with us since November. So a little modification on that, but we excited to happy Heather happily is married and moved, but thankfully she moved to an area where we have another office. So she's over there, and worked with her for 6 years, side by side. So bittersweet to see her move on, but happy for her. And many of you have met her over the years. All right. So one of the main comments I get when people jump into this TMJ sleep thing is that I just have to figure out how to bill insurance for this TMJ sleep stuff, and I can really get it rolling. I think it's the exact opposite. You got to get some cases rolling and get experience, exposure, do it fee for service, learn it, understand it, and then decide, okay, what time and energy do I have to investing into? Am I get a medical bill? There's a bunch of different ways you can do it, and to each their own. You can be all in insurance, be a network, and do that. You can courtesy bill, or you can just not deal with it at all, which is what we do. But either way, I think you got to get reps first. You got to do it. So do the low hanging fruit. Have your fees reasonable. Get paid for what you do, but you're also getting paid to learn, and get experience with it. So my advice is to figure that out first. You got to figure out how to do the treatment before you figure out all the nuances of medical insurance and all that stuff. And I commend and I'm impressed by the doctors that are in network and know all the nuances and have their systems dialed in to do it. I think it's fantastic. I hope we can stay doing what we're doing, where we can kind of pick how long we're seeing patients, have autonomy with compliance designs, and have autonomy with co-treating TMJ and sleep side by side, and not having to watch things Big Brothers over our shoulders, so that all the codes and the diagnostics and stuff aren't convoluted in the medical insurance world. Um, in my opinion, it's a lot of people that want to get into medical insurance. I say it's like seeing a burning building and wondering, I wonder what it's like in there. I want to go check it out. I think if you talk to most physicians that are in network, they have a lot of woes and concerns with insurance and how much is dictating how they do. My dad's a physician, and he said once they signed on with medical care years ago, they basically gave medical insurance companies the right to practice medicine without a license. And that's what we're finding is, you know, just today, patients pre-diabetic and is wondering why she can't get money for a continuous glucose monitor to ensure she doesn't become diabetic versus, oh, once you're diabetic, we'll give you a GCM. So it's like, once you're sick enough, then we'll give you that. So as you guys know, a lot of that doesn't make sense out there. But so my opinion is get started, get some reps under your belt, and then kind of evaluate that. So we're 100% fee for service. Every day to patients, I say cost is only an issue in the absence of value. A friend has said that to me, who's in the financial services industry, and I think that's true. So if you provide the immense value, then cost won't be an issue. In my opinion, when there's no insurance and people are parting from that money on their own, you get increased compliance. And I think that's pretty well understood across medicine. Just because something's paid for, oftentimes that comes with less compliance and less buy-in from the patient. So to start off, any questions, things you want covered, that you have concerns about or want to know more, go ahead and post it, so I can kind of address them as they come along. And so just let me know, and we'll go from there. Okay, good question. So chiropractor asked, do I see a future where dental professionals and chiropractors trained in CFR could co-manage complex airway TMJ cases? Are you familiar with the concepts like the Lovett brother relationship to TMJ and sacroiliac joint, primary respiratory impulse mechanisms, and cranial dural techniques? These play a central role in the work, and I'd love to hear your thoughts. So yeah, I mean, absolutely. We co-work with an osteopathic physician, Dr. Mark Canteri, and have had success doing that. Co-treat patients. We saw a patient today from St. Louis, saw him together working on his breathing. He did some OMT on him. And so I think absolutely the more we can get chiropractors and dentists in the same room training courses together, then locally you can work together. So I've been to courses with chiropractors, and that's how I forged a relationship with Dr. Canteri, is bringing him to courses, getting him exposed to our world, and then he exposes us to his world, and that's where we really learn what each other's skill sets are and how they can complement these patients. So I'm not particularly familiar with the Lovett brother technique, but definitely something I think has a lot of value. and would love to see it in action. Um, and then easily could kind of cross refer patients back and forth. And I think that's where communication comes in, which I'll touch upon here. All right. So some key metrics that we look at is new patients, case acceptance, and referrals, and collections as a percentage of production, which if you're doing fee for service should be 100%. Collection per day, so you know what you're collecting in clinic per day, and then you can calculate how many days per month you're going to work, and then you can kind of foreshadow what you want your collections to be for the year, and then make sure you kind of engineer your day to have the right amount of new patients with the right case acceptance to collect what you need to collect to hit your goals. So if you have a goal of $1 million for the year, you're going to work 12 days a month. You'll be able to calculate you need to do $83,000 a month. If you're charging $5,000 a case, kind of can break that down to I need 22 case starts a month. And if my case acceptance 50%, I have to do 44 new patients a month. So it's putting me at about 3-4 new patients a day, depending on how many days you work. So kind of starting with those goals and then breaking it down to the day, and you can make that schedule for the day, which I'll go over in a little bit. So some of the performance trackers we use, and question I had is who's actually tracking their case conversion? And the way we do that is we just take new patients divided by acceptance, and that's how we track it. So we're going to win some, we're going to lose some, meaning some patients aren't going to be candidates for treatment. We refer them out. I've just always kept it like that. And I know I really want to be around that 70-75%. That's when things are kind of really humming. But I hope that the 30% that don't accept, they've had a good experience. We've directed them appropriately. But I think having 100% acceptance is unrealistic because that's never going to be. And I think anybody who says they have 100% acceptance, it probably isn't casting a broad enough net, or they're not calculating it truly. So some of the technology we use, Power BI by Microsoft, so we can track our incoming referrals, and this is broad over a 3-year period. We can see how many patients we have from online and what that acceptance is, and then how much that was presented and what was accepted. And then we can see our top referring doctors, and then kind of can click into those, and it breaks down where those patients are coming from, zip code. And then, but historically, we've been about 60% dental referrals, and then medical makes up about 15 to 20%, and that ebbs and flows a little bit. I'd say, while most of our TMJ patients have sleep breathing problems that are causing their issue, they come in for pain. And that's kind of the driving concern that motivates them to come in. In my opinion, a TMJ patient's easier than a sleep apnea patient for various reasons. But a lot of dentists think the sleep is easier and want to get into sleep because they don't want to mess with the craziness of TMJ. But I think if you understand how to treat the TMJ, it's actually easier to treat a TMJ patient with a main chief complaint of pain than it is a sleep patient. Happy to discuss that at a different time. So kind of just looking at our tracking system to give you some context, I can break down our case acceptance by the clinical assistant. And we can kind of look at, okay, what clinical assistant has the highest case conversion? What treatment coordinator has the highest case conversion? And then as a provider, our nurse practitioner versus me, based on a period of time, we can pick, okay, who's got the best conversion? And then we can track that and see, okay, why is it high 1 month? Why is it low 1 month? And then we can make informed decisions along the way. So Power BI has been a great tool. We also use it to track our calls coming in, so we can see how many new patient phone calls we get, the appointments that are kept, and their schedule rate, and then by employee who's taking the call, what their close rate is on getting the patient scheduled. And then, so we track our new patients by who we're seeing in the office, but then also by who calls as well. And so that's what this breakdown is here as well. I think last year we had over, 340 unique providers refer to us, if you count one new patient. And so if you think about that, that's all the marketing we need to do is to those existing people. And if we can get those people to just refer one more patient, That's a heck of a year, just getting one more patient. So I wanted to talk about some effective strategies to gain influence in a marketplace. And so this will kind of be rapid fire, and then hopefully it generates some questions. But here's kind of 10 things, and I'll go through them briefly, and then I have some slides to talk about it in greater detail. So host local info nights. So we've done a lot of that, either where I speak, my nurse speaks, or other doctor, or we bring in a local professional, another orthodontist or something like that, and just host info nights. And we do that twofold. We host them for patients, prospective patients, existing patients. And then we also host it for doctors, hygienists, and such. Hygienists, CEs are probably the largest attended. Hygienists are always looking for CE, and they're very intrigued with the whole TMJ sleep airway world. So routinely, if we host a hygiene night, we have 40 to 50 hygienists, and they're seeing 8 patients a day, and they just are some of our best referrals. So while a lot of the referrals say Dr. Fursley referred, it's really the hygienist at Dr. Fursley's office who sent it to the patient, and the doctor just agreed to it. Number 2, call the doctor. I always find a reason to call a doctor I want to talk to, or I've been looking to get in touch with. So if I've been meaning or trying to get a hold of Dr. Fursley and I haven't been able to, and I see a Dr. Fursley patient, whether or not he was referred by them, I'll then be like, hey, Dr. Fursley, Daniel Klauer calling here. Love to touch base about a mutual patient. And then he kind of has to call you back, right? You know, as a provider, if you're calling in regards to a mutual patient, you kind of have to get on the phone. I think it's a great opportunity to connect with them, share cell phone messages, and then start texting back and forth. And we utilize something I learned from Scott Manning, the triangle of trust. So at all point in time, there are 3 people in the room fostering that relationship. So at our office, it starts with the admin, the clinical assistant, and the new patient. They get introduced, and that's the triangle. And then I come in, and it's me, the assistant, and the patient. And then the treatment coordinator comes in and kind of coordinates with them. So the patient always has an advocate, but then also patient knows that 2 people heard and are a part of the conversation. And especially when finances come up, if I go over the finances briefly in front of our treatment coordinator, the patient can't say, the doctor said insurance would cover it. Oh, the doctor said it'd only be this. The treatment coordinator can't go, no, he didn't say that. But if the treatment coordinator is in the room, the patient can't, not maliciously, but unintentionally, kind of pin the doctor again and make for an awkward situation. So we always have that triangle of trust going on in the room. We ask every patient for a victory. So there's a sticky note that follows them around the office, and we ask them, what's a victory for you today? I heard today a patient was to not be tired so I can play with my grandkids. So that was on a sticky note that followed her around the office. So anytime I spoke to what her treatment plan would be, I said, now, in order to get you feeling better to play with your grandkids, this is what I would do. Because then it's speaking in their currency, their words of what they want to accomplish. I do a lot of video summaries. I'll show you one in a little bit where we screen share it, relay and repeat. So when a patient comes in, they tell their story to our clinical assistant, and they relay that story to me, so the patient gets to hear it again. And then when our treatment coordinator comes in, I relay the story to the treatment coordinator to say, hey, this is why Bob came in. This is what we're going to do for Bob. This is what the investment's going to be of time, energy, and money, and relay and repeat. So they're hearing it multiple times. I have a sheet of some stock analogies that I put together for our nurse practitioners just to help explain what's going on in these situations. So that's good for my team to use to break it down into layman terms of what's going on. We collect a $100 deposit for a patient to get on our schedule. That's helped to really make sure that people coming in are primed and ready to attend. We had an issue during COVID of people canceling, and I was booked out quite a bit. So we just went to a $100 deposit to hold your spot. And when people are ready, it really hasn't been a big deal. I always try to use the words that uses in describing their problem. So if they say, my jaw has a gravelly sound, I don't say, well, yeah, the crepitus in your jaw is this. They're going to be like, what's he saying? I said, the gravelly sound in your jaw is this. because it's their words, it's their experience. So I just use that as I'm explaining what's going on. So if a patient says, I'm gargling at nighttime, I don't say, well, it's snoring from your sleep apnea. I'll say, your gargling at nighttime needs to be treated. And then we utilize a lot of photobiomodulation. We have 7, 8 different lasers. What's great about the laser is you can prove to a patient that you can help really fast by lasering in the right areas, and using the right modalities to quickly get a patient out of pain and prove to them that you can move the needle on their pain. And so it's a big way to gain influence on these cases. Uh, all right, let me just peek at some of these questions. All right, so while it's on the topic, uh, someone had asked about internet marketing. So I think the best thing that we've done on internet marketing is keeping reviews high, engaging in social media, and then Google AdWords and stuff like that. But to be honest, I think a lot of the internet success is my local connections with the providers. For example, someone might put Google, but really they were at Dr. Jeff's office. The hygienist said, you should look at Dr. Klauer. They Google me, they see our Facebook page, they see our engagement online, and then they learn more about us on our website and they call, how'd you hear about our practice? And they'll say Google. And it might happen the opposite. They may Google us, learn about us, go to their dentist and say, hey, Dr. Jeff, I read a lot about Dr. Klauer's office. Do you think that'd be a good fit for me? Yeah, I would. So they'll put down Dr. Jeff. So while we track it, it's not always true. But sometimes go into detail with the patient and be like, oh, so Dr. Jeff sent you in. Tell me how that came about. Oh, well, I found you online and I was getting my teeth cleaned. I asked about you and he said, yeah, you're good. So really, is that Google or is that Dr. Jeff? It just kind of depends. But we've been working with a company that helps us optimize our search engine presence, our local presence, and all of that stuff. But I think the community outreach, the local webinar, the local seminars, the get-togethers, we had an open house last week, or June 28th, and we had over 500 unique people come by our office that day. 500. And we had food trucks, we had games, we had a golf simulator, we had Connect Four outside, we had bags, we had face painting, jewelry making. Made it really just a community event. We had a shuttle from a local church parking lot bringing people over, and probably cost us under $10,000, and had 500 unique people come through. Some were patients, some were providers, some were just people in the community coming for free food. But that was a great event. And I think that community engagement is why we see those numbers and the influence of new patients. These are some of the books, How to Gain Influence, Dr. Cialdini, a lot of you probably know. Recent one I read is $100 million offer. It's funny, you read that and it's all about how you phrase what you have to offer. And what we do is, in my opinion, nothing optional. So I'm fine with presenting that stuff very clear to them. Okay, one question. Most chiropractic patients, head check are 100% preferable to a DDS. They already been consulted, educated, tested, and diagnosed, primed for TMJ sleep. Yeah, I think a lot of patients that go to chiropractic care have those symptoms, and yeah, that's certainly stuff that we can co-treat and see. I think that intracapsular cartilage problems, managing the parafunction is very important, and so I think PT and chiropractic care for some of those intracapsular problems will have a limit of how much they can do. But if that chiropractor is well versed at breathing education and doing some of that stuff, then I think it can be more profound. All right, so solution to the problem. So we had a problem of new patients not showing up or having some cancellations. So I just texted this right after this was probably 3 months after we implemented it. I said, overall, how are the $100 deposits going? This is Jillian at my office. Great. I said, no resistance or shock when asking. She goes, nope, sometimes they ask about insurance, but not usually. And we all have our insurance verbiage down pat, so it's easy to dismiss. So we don't take insurance. It's on our website. It's on our paperwork. We don't process insurance. We will give you the codes, but I'd say less than 20% of patients even ask for the codes. We kind of just shut it down at the beginning. And most people know insurance is tough and stinks. So some verbiage and fees. Broadly speaking, not every case is the same, but if I consult with someone, the consult is a review of the medical history and to help kind of get eyes and ears on the situation and see if it's something I would move into. So for $100 consult, I'll tell the patients. Now, typically, if we do an exam, after I do the examination and we need imaging, you could be in that $700 to $800 range for the exam, imaging, workup, diagnostics to understand what's going on with your problem. So that avoids sticker shock, and at least they know, okay, to find out what's going on. And a lot of times that's what they just spent on a mouth guard. And they'll go, well, that's what I spent on the mouth guard. And I said, oh, that's interesting. I would like to know what's going on before I spend money on a modality. So that's where I think the diagnostics are very important. So I can't possibly know what to do without evaluating you. Well, why didn't my dentist just make a mouth guard? It's like, well, in dental school, we were taught the TMJ, make an appliance, make it for the upper. That doesn't work, make it for the lower. Go around the corner, say an Our Father, and hope the patient gets better, because after that, we haven't taught you what else to do. So I tell the patients to do an exam, imaging, and workup, likely be in that $700 to $800 range. Then once we know what treatment is and I have my game plan established in my head, I'll say, now, Sally, a case like yours, a patient could be in that $6,000 to $7,000 range for therapy, treatment, kind of everything we do over that course of time. I'm going to have Taylor go over all the logistics, answer any questions you may have. It sounds like you're on board clinically. You told me it makes sense, and you told me that you'd able to be compliant with this. And you told me you want to get this treated. So now Taylor and you can just sort out the finances and logistics and the schedule that we can get this going for you. While I'm still in the room, any other questions regarding the clinical aspect of it? And that way I can preface what the financial commitment's going to be. I know my fee ranges based on what I'm going to do. And I can foreshow it, so it's not sticker shock when the patient sits down with the treatment coordinator and can claim. So I'll have patients go, oh, wow, that's a lot. And I go, what were you anticipating? Well, I thought it'd be $5,500. I'm like, oh, great, we're only $500 off. You and Taylor should be able to sort that out. Good. I'm glad you anticipated what this was. If they've just had an implant, I'll say, oh, it's about the cost of an implant. If their kid just had ortho, I say, oh, it's less than the cost of orthodontics to straighten some teeth. And try to reference it to something they've purchased, they've bought, they've done. If they just told me they got back from Disney or they have a BMW key ring, one thing I use commonly is we see a lot of Notre Dame patients, and Notre Dame is $85,000 a year. So if I have a Notre Dame professor that says, well, I think I'm going to try to find someone that does it through insurance. And I said, okay, you may ask why? Well, then it's covered. I was like, okay. And do you feel like the treatment would be the same? Like, yeah, I bet it'd be the same as long as it's covered. I said, so there's no difference between Ball State and Notre Dame? Like the professors are the same at both places? He goes, well, what do you mean? I was like, was Notre Dame a premium education? Is that why people are paying for it? And premium experience and value in it? Well, yeah. And I was like, great. Well, I hope Notre Dame students, I saw the value in going there. And I hope my patients see the value in seeing me versus just doing what's covered by insurance. So I try to bring in an analogy or a comparison to something they've shared with me in their life that can kind of draw a connection to why I think the investment is worthy. But ultimately, yeah, I tell patients we wouldn't be here 13 years with success in a smaller town of 80,000 people if we didn't continually get people better. We wouldn't have 400 plus unique providers referring to us every year if we didn't consistently get results. It's a small enough town where word would get out. So Dr. Paul Homily, he gave that advice, and when it clicked on the money talk to avoid sticker shock, he's like, just throw it out there. Like, let them know. Don't hide behind it. Don't try to justify your fee. You'll lose when you're like, oh, wow, $5,000 just for the plastic. If you start to justify, well, the plastic is this, and the bite is this, and then we do this and we do that, like that just confuses them. You go, yeah, to get you the result, that's what it's going to cost. And they shut down and they usually stop challenging you. But if you try to prove, I think you chase the case away. So here are some analogies that we use with our patients. I have a document. I give it to Shay. She'll send it out to you guys. but I think that just gives you some context of things we use, how I talk about it. And then this is a great book. Um, it's an easy read. It's Exactly What to Say by Phil Jones. I'll go over just a little bit of it. But the worst time to think about the thing you're going to say is in the moment when you were saying it. So this is why we practice, right? So we practice so it doesn't have to be thought about. It's almost reactionary. And so the more we do of a certain technique, the less we think about. I remember watching a dentist and it's like, oh my gosh, how do you prep in a mirror number 15? Like the moment the dentist thinks about going left, right through the mirror, they fail. It's repetition. Basically it's on repeat. So the book kind of prepares you with a verbiage for some of these situations. So your brain goes straight to the subconscious, uh, and your goal is to help people achieve their health. And so you can only do that if you get them to say yes to what they truly need. So as long as you're ethically utilizing this stuff, it makes a lot of sense. So here's some key lessons. And I got the cliff notes and I wrote out some things that we use. I'll go over a few of them. But if you have a very closed off patient who thinks their problems related to something else, I would usually say, all right, so based on what you told me, I'd like to share my insight. And you kind of pause and say, do you consider yourself to be open minded? And everybody says yes to that. Almost everybody. I say, great. Well, I think your jaw problem is related to your nose and your sleep apnea. Would you be open to doing a sleep study? Because I think that'll really give us some insight into what's going on. And usually then they'll say yes. If you feel there's resistance and they're not going to believe that their migraine is related to their jaw, say, so what do you know about migraines? They'll say, nothing. Would you be interested to know what I know? And they'll say yes. And then you share with them. There's two types of people. There's two types of patients I see. Ones that want to be proactive and stay ahead of problems to save themselves time and energy. And then there's reactive patients that once, once all the wheels come off and once they're at rock bottom, then they're going to respond. Which type of patient are you? So as I prepare your plan, I know what's going to be best suited for you. And just out of curiosity, what did you anticipate to learn today? Or just out of curiosity, what did you think treatment would cost? And it can get them to talk and understand more about what their objection is and how to help with case acceptance. It's also good to have a sequence if they don't accept. So what do you do when a patient isn't ready to move forward with treatment? Do you have post appointment educational material? Do you have resources? Do you have follow-up? We've done, after a quarter, we'll do a webinar reviewing active cases, and we invite all the patients who didn't accept treatment and say, hey, Dr. Klauer is hosting a webinar going over some recent cases. He thought you might be interested in attending so you can learn about your condition and on how you're not alone and other patients are experiencing it. So we'll rally the patients that didn't accept, and we'll just do a Zoom specifically for them, just going over some active cases. And I usually just pick what's going on in the schedule. Patients chose to walk through our door for our advice, our opinion, and our help. So it's up to us to educate them so that we can get them the help they need and deserve along the way. Pre-education is vital. So we pre-educate all new patients and we try to pre-educate the community. We want to build the authority before they arrive. This is a funny story. I wrote a book in 2017 or 18. It's just patient vignettes. If you want a copy, email me. I'll mail you one. And it's great. It's nice for patients to see what we do. The owner of Advantage Media came into my office. He's a friend of mine, and he came in my office last year, and he goes, you need a sign for your book. And I said, all right. So Adam sent me this, and he mailed it to me, and it's in my lobby. You'd be amazed at how many people that I've been seeing for years are like, hey, doc, congrats on the book. The book's like 5 years old, six years old. Like, hey, congrats on the book. And so just moving this sign around. So every other week, the team just moves it somewhere else in the office. and it still amazes me. Almost every day, someone congratulates me on the book, and it's just funny. So we did a Valentine's CE for hygienists, assistants, physicians, and dentists. Had a good turnout. So here's hygienists and dentists kind of do a whiteboard session. And then we have food set out here and some drinks. We've done like champagne and charcuterie, try to kind of pick a theme and able to fill the room with a captive audience. And usually half the time is content and half the time is questions. These are the 3 posters we have in every room. And sure enough, when patients are waiting for me, they stand up, they start looking at these posters and they take pictures of it. And so we just have those in the room. I use them as I'm talking to patients, and it helps to educate them. It's really, really valuable to show the patients their problems. So we do like recap summaries. So after an exam, I'll do a screen share on my computer. I'll pull up appliances. I'll pull up their CT scan. And in about 6 minutes, I'll walk through their case start to finish. So they have it as reference for their loved one who didn't come. But then as I communicate with other doctors, here's a unique case, a bite change that was really arthritis in the jaw joint. Prosthodontist kept doing new crowns. And this was my way of communicating to the prosthodontist and the dentist.
Hey everyone, Daniel Klauer here from TMJ. Just wanted to shoot this summary for our fun, sweet patient Anne, and then also give a copy to Anne and her husband. So Dr. Zimmerman, Dr. Picard, thanks for collaborating on this case. As you guys know, back in 2022, Anne had kind of a second bout of COVID, or after the booster, had just a severe infection. Looks like tooth number 30 was decayed, and then got a bridge 29 to 30. And ever since that bridge, she's just had bite problems. Spent about 3 hours with her yesterday. Looks like the tooth's dying. She's got these periapical abscesses. So I imagine that'll need to be treated. Is a couple things. We're going to make her orthotics to wear, one during the day and one at night. So the daytime orthotic will be a kind of like a gelb or a lower built up in the back to give her support, give some posterior height to create some space in the joint. And then at nighttime, she'll wear kind of an anterior to programmer type appliance with a loop that prevents protrusion of the mandible times throughout the night. Again, she's unaware of a lot of this because it's happening. I think number 18 can be looked at, but I thought this was the easiest way of kind of communicating.
So I send this to the referring doctor, I send it to the treating physician, I send it to the patient, and I try to use terms that they know. That doc was like older school, and I've seen his cases. He's done gelbs and different things like that. So I kind of try to use terms that I know resonate. This was actually the kid we saw today from St. Louis. I sent this progress video to Dr. Movahead, who referred him to me, and Dr. Mashiri, the orthodontist in St. Louis. So this is a video summary. Just, hey, patient's doing great. Here's an update on him. And, his jaw pain is 80%, neck pain 80%, 90%, 100%. So he's doing well. This was a while ago, but he was in today, actually.
Time and nighttime appliance. How is everything going so far?
It's a lot better.
Yeah. How is pain, jaw pain?
Jaw pain's basically gone. I get occasional here and there, but not bad at all like it was.
Okay, and then so he has been working with Dr. Canteri as well. He just saw him today. What is the plan with that?
Canteri, he's kind of helping me strengthen my body, get me out of a cattywampus position, and then they recommend PRP because I have a tendon in my arm and my back that needs work.
And then we also really worked hard on addressing the nose. He ended up having surgery with Dr. Gilbert. What are your thoughts of that?
I am now dreaming. You don't think about it until you have the surgery, but so things are better too, yeah.
Good, I love that. I'm really happy for you. Dad, do you have any thoughts of how treatment's going?
I think he's doing really well. We have been to several doctors, and I just appreciate Dr. Klauer's working with other people. We live 7 hours away from here, and he's got us working with 2 doctors in St. Louis, and it's just I appreciate that they're working together to try to help Chase.
I love it. Thank you, guys.
Thank you.
So that's kind of just an easy way to communicate with patients, doctors, etc., and keep them engaged. So video communication. So I've made referrals. I'd say, hey, Dr. Jeff, I'm here with Sheena. She's excited to come see you to have the nose evaluated. Here's her CT scan. We'll send it to you. But Sheena, I think you'll really like Dr. Jeff. He'll be great. And now they're kind of bought in. We'll also say thank you for success. I'll be like, oh my God, I'm so glad you're doing well. Hey, let's send a video to Dr. Harrington and let's let him know how well you're doing. Like, hey, Dr. Harrington, Daniel here. I got Steve. Steve's doing great with treatment. Steve, tell him how you're doing, and you wanted to thank him for referring you. Hey, Dr. Chad, thanks for sending me over. I'm feeling great. I really appreciate you sending me to Dr. Klauer. And then with their permission, you can share that stuff online. So we send updates. If there's any concerns, I'll send a quick video. I'll explain what my concern is. Hey, Sue, give me a call about Mrs. Jones. I'm concerned about the margin on number whatever and want you to look at it. And then if we get new technology or we're doing new procedures, new blocks, different things like that, I'll shoot a generic video and then I'll just text it out to my contacts to be like, hey, doc, haven't talked in a while. I just want to know we got this new technology at the practice. Here's an example of it. And if you have any questions, let me know. I get a lot of docs that'll shoot me consults over the phone, like, hey, I got this going on. What do you think? And I try to guide them as much as I can to have them independently tackle it, knowing we're we're trying to give information forward and help them. So with the Microsoft OneDrive and Stream, through that it's HIPAA protected. And so you just make sure it's a HIPAA protected platform and or you get the patient's permission and it's documented. And then you don't have more than 3 patient identifiers being shown along the way. And there's different portals that you can send that stuff through. All right, so the marketing technology and systems that we utilize, and then we can open it to questions. We utilize Power BI. If anybody wants an introduction to Avi, he's kind of the tech guy I found out in Washington. He's awesome. He set up that whole platform for us. Wasn't too expensive. And then he touches base with us once a month. Charges $100 a month just to manage it. And he's a good dude. He actually flew out to spend time with us. That's now integrated with Pure Logic, our AI phone system, HubSpot, and Salesforce. We use Doctable. That's part of our patient texting tracking communication system. We use OneDrive, Microsoft Stream to do our video recordings. There's Loom, Bandicam. There's a bunch of different kinds. And then we utilize ChatGPT and some AI apps quite a bit for marketing. So we can take our Power BI data, we can throw it into ChatGPT and say, Jillian has 6 hours to do drops. If she spends 7 minutes at each office, what's the most efficient driving route to hit the top referring offices in one day? And I'll say in one day you could hit 14 offices and it gives you drive-by-drive directions. Would you like to import these directions into your phone? And basically she can just go next office, next office, next office. And ChatGPT gives her the most efficient route to get there. It tracks her mileage so she can be reimbursed for gas. And it tells her what she can feasibly get accomplished in one day. So like so many things you can use that for, which is really cool. So she uses that all the time when she wants to hit a region. So she'll upload our data into ChatGPT. You can even upload data into ChatGPT and hey, tell me the most unique find trends that you see in this information, and it'll spit it out, which is really cool. So I think we underutilize that, and I think we'll get better and better at it. So our demographics, historically speaking, we've always been 65 to 70% female, 30% male. And that's over the course of like 6 years of tracking this stuff. And the average age is always in that 35 to 40 range. So, and that's just kind of our sweet spot of patients so that we know who we're marketing to. And then we can track case acceptance by age demographic. And definitely the boomers and up are higher case acceptance. And then the 35-year-old females have a high case acceptance. So we can kind of see that here in the age demographic, and the younger patients in pain tend to have less case acceptance. Then we can look at our demographics and where our patients come from by zip code, by mileage. And again, then Jillian knows where to invest her time into her schedule and all of that based off the demographics of where our patients come from. So team management, you kind of look at, let me see the time. All right. So kind of look at what you can legally and ethically delegate. And I guarantee there's a lot of things you can legally and ethically delegate and empower your team to do so, give them more autonomy, more ownership in their role, and more fulfillment as well. And so what are you doing that your limited mindset is holding on to? So I guarantee there's some things you're doing clinically and managerially that you think you can do best. But Dan Martell in his book says 80% delegated or yeah, 80% or something delegated done 80% well is 100% awesome. So if your team member can only do it 80% as good as you can, if you can delegate it, it's 100% awesome. And obviously within reason, clinically speaking, but you'd be able to serve more, have a better patient experience the more involved you get your team, because you can only go so far. And then you got to make sure you're the one leading culture, and you have a good culture and it's healthy and the team wants to be there. I say this: I want my team to love walking in the door, and I want them to love walking out the door because they're going home to what's most important, family. And what have you done to invest in your culture? So a lot of times I feel like doctors are cheap in investing in their culture, team experiences, and fun activities. And while you may think it's a waste of money because it's not important for you to go bowling, you don't need to go bowling, but your team has camaraderie and they want to go bowling, take them bowling and pay for it and have a good patient experience. Kind of an example sample schedule. We'll run usually 5 or 6 rooms depending on the day and the assistants we have. Yellow are new patients. And then orange are ones that I have to see, meaning the patient has requested or the nurse practitioner can't see. And then we block about 2.5, 3 hours for new patients because most of the time, 90% of our cases are same day starts where we get something started that day. So it's kind of just a sample schedule. I see patients Monday through Wednesday. It's not on Thursdays. It's the nurse practitioner only. She'll usually see 1 new patient, and then she'll run 3 or 4 columns. This is all myofunctional therapy, so the nurse is running the other 3 columns with assistance, and sometimes we have a flow. Got to have accountability, so it's just an example of an accountability chart we have for practice, laying out duties and everything. And then, does your team know your expectations, your mission statement, your core values? And that's how you kind of build the culture and make sure it's visible, it's clear. Patients love seeing this in the office. They read it. And then if you have an issue with a team member, you can be like, hey, was that transparent communication? Was that authentic? Were you providing hope? You seem to be lacking passion in what we're doing. What can I do to help? So these are all talking points if you have to have those hard conversations with employees. It's not me saying they're not transparent. It's me referencing, hey, we agreed to be transparent. I feel like we're falling short. What can we do? So I know that was a little rapid fire, but have plenty of time for questions, and we can ask away, and I'll try to pull up the Q&A, or Shay, I know, can help me out with that. And we got about 5 minutes, but I can stay on longer.
As of right now, it looks like the only one maybe you haven't answered is, how do you share those videos securely?
So I would just look at the different platforms you utilize. Microsoft OneDrive is HIPAA compliant, and just making sure you're not having more than 3 patient identifiers on the text message. So you can send like date of birth and initials to reference a patient. And oftentimes I'll send something, and then I'll just call and leave them a quick voice text of like who the patient was, to make sure. And there's a lot of apps too. Different hospital systems have HIPAA compliant apps that we communicate through based on the system. So I would just make sure you do your own research and make sure it's you're protected, as those fines can be pretty steep. And usually it's for the patient's benefit. So a lot of times, patients are happy that you're doing it. Do you send a referral letter also? Yeah, we always send the letter via fax or email, but I mean, 99% of the time they don't read them. So if you really want to engage a doctor, I think you got to text them or you got to send them a video, because they're not going to read through. And so many people send me hey, what do you think of this letter? And I said, I'll sometimes say, I wouldn't read it because it's like patient presents with this, this, and that. And my exam showed range of motion of 46 millimeters with 5 millimeters excursion to the left and disc displacement with reduction on the right. I'm going to do, they don't want to hear that. So usually my verbiage is, case, I saw a kid Mace today, he's 16. And I left a message for Dr. Garrett. I said, hey, Dr. Garrett, I saw Mace. Thanks for sending him over. Yeah, you're right. Mace's jaw's clicking and popping a lot on the left. That disc is out of place. He's got a profound nasal obstruction. So what we're going to do is we're going to treat the jaw joint. We're going to use an orthotics and laser therapy, maybe an injection, get the joint stable. But we're also getting him over to ear, nose, and throat specialist because he's got a huge deviation. So if we get him breathing well through the nose, load off that joint, get the joint to heal, I think long term he'll do great. Hey, if you have any questions, you'll get my formal letter. If you read through it and have any questions, just give me a shout. Let me know. Thanks for sending Mace over, and parents were super appreciative, and we look forward to treating them. So kind of keep it simple because they'll listen to a voicemail, they'll read a text, but I'd say 90% of your letters don't get read by the doctor. There's another question here. Any suggestions for patients to gain reimbursement for their medical insurance by self-billing? Yeah, I've seen some offices split up the CT scans into panos and skull PAs and stuff like that. We had done that for a while. I don't know. I just kind of got burnt out trying to navigate the insurance waters, and so I just really don't participate in trying to do the gymnastics. I think my time's more valuable helping patients and treating them. And so I haven't really seen a consistent, successful way of getting them reimbursed overall. So we just have a CBCT code that we bill, and then oftentimes they'll say, "Hey, will you code it as this?" And my team says, Dr. Klauer already coded it, and ethically, I can't go in to change it. And this is what he's been advised to code as. And your insurance company may be telling you something else, but Dr. Klauer already coded it for what he felt was most appropriate. And where can DCs showcase? I guess I don't know what you mean by that. Oh, that was it. So unless you see anything else on your end, a couple
more came in Q&A. If you could get a new patient referred who examined, tested, and diagnosed with UAOSA from a doctor of chiropractic, what could the chiropractor do to pre-educate, pre-examine? Could you do a focused exam and scan for an oral appliance? And how valuable would that be for a DDS?
The chiropractor, I don't think many dentists would be thrilled with them scanning and doing appliances. I know it hasn't gone very well for the ENT world, scanning and doing appliances. But I do think from a pre-education standpoint, a chiropractor talking about how impaired nasal breathing causes forward head posture, which can cause a whole host of chiropractic issues. So I think that pre-education is good. And then stressing, hey, I can definitely help you, and let's engage in treatment. But to have the most durable and sustainable outcome, I think getting my dental colleague on board would be great, so that we have the best outcome for you long term. So I think that type of pre-education and knowing that patients are complex, so one provider for these complex problems oftentimes isn't enough for you. What do you do with the bite after orthotic is done? Do you leave open bites? So what can a DC do to best send a referred patient? I like what I said. Just educate and kind of pre-program. But the more you know the provider you're sending to, the more you can explain what they do and everything. What to do with open bites? It just depends. If a patient's apnea is being treated and they have a little open bite, not a big deal. It doesn't really matter. I see a lot of jacked up bites that have no TMJ problems, and I see a lot of perfect bites that have TMJ problems. So we try to um, prevent open bites and bite changes as much as possible, and we try to educate the patient on how to be cognizant of that. Um, uh, but if we control the parafunction and they're not over, leveraging the appliance and turning it into orthodontic appliance. But yeah, we get bite changes. It happens, and just try to educate the patient through it as best as possible. How much fee explanation does the team go over on the initial? Very, very little. A lot of patients will ask, but we'll say, well, it's $100 consultation. And then in that consultation, based upon what you need, Dr. Klauer and the team will be over to go over any investments before they incur. So the patient will never get a bill from our office. Everything's discussed beforehand. We don't send out statements. Everything is kind of pre-collected and pre-discussed. So we try to minimize that on the phone because it's not productive. You just get trapped. So our team is kind of trained to kind of control that conversation on the phone, advocate for the patient to see a provider, and how to best establish a relationship with a practitioner. Honestly, I think the worst thing you could do is walk into an office with a folder of information and stuff to give them. In my opinion, I think that's the worst way to lead into a conversation. It's like going on a date and bringing them medals and trophies and pictures of everything you've done to try to get them to like you. It's like, hey, look what I've all done. And this is what I can do. I usually go in new providers with nothing and just conversation, and ask them a bunch of questions, ask them what they like. Any question I want them to ask me, I'm going to ask them first. Hey, so what type of patients do you like to treat? And what if you had an ideal patient come into your office? Who is that, and how would I get them to you? What have you found to be most successful in treating these, abscess teeth? If you're talking to an endodontist, what's your biggest frustration with the TMJ complaints you see at your office? So I just try to interview them and ask them, and it's kind of like dating. You just gotta make sure you can kind of connect and relate. And then I always try to get their cell phone number. Like, hey, moving forward, are you cool if I just like text you questions about this? Are you okay communicating like that? And 99% of the time they say yes. So I just think going in to genuinely get to know the provider and understand them is best. I think the worst thing you can do is walk in with a referral packet in the folder. Now have them in your car, because they're going to say, hey, do you have referral information? Look, I think I might have some in my car. I can drop it back off. And then walk out to your car and get it. But I rarely come in with that. Is there a clinical protocol? Yeah. Yeah. So the American Academy of Dental Sleep Medicine's got their published protocol for dentists to follow.
Awesome. Great advice. Yeah, I think that's it. A lot of messages coming through on my end, just thanking you for the great information, and yeah, just appreciating your time for being here and presenting to the community tonight. We thank you very much.
Cool. Well, Shay can send you some of that information on that book and some of those analogies that I've learned from other people and kind of put together. So if any questions pop up, you guys got my email right here on the bottom. More than happy to field any emails. But good luck to everybody. Hope everybody has a wonderful rest of the summer. And thanks for attending, and have a great evening.